Hey guys, so we're going to be talking a little bit about our meds today. Unfortunately, Dr. Narcan couldn't make it for all the trainings, so we thought the easiest way to do it would be to just do one film session and try to bang it all out like that. Couple points that I just wanted to talk about was there's going to be a new binder in all of our stations. It's a red binder, it's up on the wall. Should be closest to the door when you first come into the stations. What that binder is, it's the Policies and Procedure Manual for Dr. Narcan himself. It actually says Dr. Narcan on it. We just wanted it in an easy location to where he could come in if he needed to do his quarterly reviews, just to be able to come into the station, open it up and find all this stuff out there. So just kind of wanted you guys to be aware of what that is. What's going to be in there is the policy and procedures, the pharmacology and the drug sheets, the incident usages for all the stations. I think that was it. There's not going to be a binder at Station 1 just because we're going to keep it all over here at Ops. So if we are getting inspected and somebody's looking for that manual, you can defer them to me and I'll try to find it for them at the Ops building.
The reason behind it is the Board of Pharmacy, they do inspections to each clinic, or sometimes they'll maybe only have time to go to 2 out of the 6 stations. 6 stations, right?
Yeah.
Okay.
Yep.
So 2 out of the 6 stations here, and so like this last visit they only went to 3, and they wanted to see info on that particular station instead of just going to Station 1, which had all the info. So that's why we're having to divide everything out. And so each quarter I'll come and review the incidents for that particular station and then document that I was there and if there was any concerns at that particular station. So shouldn't be really anything major of concern that you guys have to deal with. Just make sure that that book's in place for me when I get there.
Alright. So now that we have Dr. Narcan here, I was going to see if you could talk to us a little bit about our pathophysiology of our drugs and some of the indications, contraindications, stuff that we need to be looking for.
Sure. So, I know we've done this every year for the last few years. A lot of you guys are veterans with the meds. Some of you might be new, and so we'll just do a quick review. I know you're gonna, after this video presentation is over, you're gonna sit down and do some actual training. But just wanted to cover again just the basics of the medications, and then we'll also talk about the indications and contraindications. So as far as our first medication, which is albuterol, if you remember, the main mechanism of action of albuterol is when somebody is having asthma attack, then they are having constriction of the lung tissue. And so albuterol works as they call it, a beta agonist. It'll go and actually attach to the lung tissue itself and help the lung tissue expand, allowing that person to breathe more effectively. Respiratory rates go up. Indications for albuterol is wheezing, obviously associated with asthma, COPD or emphysema or chronic bronchitis. Obviously there might be some issues if there's a drug overdose, that we'll have a situation where we might need to be using albuterol as well. I think there was a case report of that last year, so be aware of that as well. Very few contraindications with albuterol. Very rare to see an allergic reaction because it's a typical chemical that the body almost naturally produces anyways, but there is a small chance for a hypersensitivity reaction. Do they have copies of this in the?
They should have copies of that in our medication books, in the blue books that we have.
So there's some reviews of some potential drug interactions with some of these meds, and it would be might be good to every once in a while as a unit or at a station to just go through those and make sure that you know what drugs are have a potential interaction with those. So second medication is aspirin. Obviously we're using aspirin primarily for the chance someone's having a heart attack. We're using that for its anticoagulant effect. So same thing, what we're looking for, indications, myocardial infarction, and then what we're trying to do is just make sure that we keep the blood thin until medics arrive. Contraindications there, same. Potential hypersensitivity to aspirin, very rare but possible. Bleeding disorders if they're on warfarin. So, you know, if somebody's on, if you happen to see someone in the house that says, oh, they're on Coumadin or on a drug called Lovenox that makes that's an injection that makes their blood thinner, those things would be need to be aware of, need to document. But at the same time, doesn't change the fact that you're still going to administer things the same. So Narcan, obviously we have covered that every year, but Narcan is opiate blocker, so we're using that to reverse the respiratory depression. That's the main indication of why we're trying to use Narcan, to stop that from an opiate overdose or illicit drugs. So we're going to indicate again, based off those guidelines, reversal for the narcotic effects. Again, mainly respiratory depression due to narcotic drugs, whether injected or administered in the course of treatment. And you know, the binder again lists most of those drugs, but we should be aware of, you know, the ones that are most commonly used. So morphine, codeine, Lortab, hydrocodone, heroin, Dilaudid. Those are the ones that you're probably going to see most out in the field. And then other indications is just for unconsciousness of unknown etiology, to rule out or reverse the narcotic depression based off of signs and symptoms that we'll go over a little bit more when we start to talk about the case reports. Contraindications, again, you know, the docs, when they put this together, they have to put hypersensitivity. In all my years, I've never had anyone have a hypersensitivity reaction to Narcan. Obviously, they'll have a reaction to the reversal of the opiate, not in the system, but not an actual a reaction to the Narcan itself. Very, very rare. Epi, we've obviously in the last year just switched from the EpiPens. We did our training last year on the adrenaline or the Epi vials instead of the EpiPens. Indications again that are severe bronchospasms that are unresponsive to albuterol, anaphylaxis, cardiac arrest, and symptomatic bradycardia. So again, for those that might be new, what we're trying to do here, somebody that's having an anaphylactic reaction, we're having vasoconstriction in the lungs and the throat, multiple areas of the body. So the goal of this medication is to try to open up airway as quickly as possible, also open up blood vessels as quickly as possible. And so that is what we're trying to achieve with Epi. And we'll, a little later on here, talk about, we've had one just recent case report that was done the way it should have been, and we'll cover that. Don't think there was any others that we needed to cover. So I think that covered all the indications that we needed to cover as far as the meds. So.
Okay. So as far as the meds go, I'm just gonna kind of touch on documentation really quick. Everybody's doing an awesome job with the report. When they're putting the firehouse report, a lot of the reports were coming back with they're saying it in the report actually in the documentation, but then they're not checking the box that says the respiratory rate, so they're just kind of going through there. So if we could actually just try to get a respiratory rate there and make sure that we're noting that they have wheezes if they have them. As far as aspirin, we're not doing the OPQRST. Once again, it's getting it's getting documented in the actual firehouse report, but just when it comes to those boxes, it'll say like not performed by FFD. And then if you're administering Narcan, make sure that we're checking pupils and we're getting a respiratory rate for Narcan as well.
So the reason behind all of this is more covering ourselves, in case of any question of what occurred during an actual event. So, as I come through on a quarterly basis, one of my responsibilities is to actually go through and look through these case reports. The Board of Pharmacy, if they need to, will also go through one of these case reports. The only reason they would probably do that would be as if there would be ever some question if something happened to a particular patient and the patient themselves or the family member wanted to know what was done in that particular event. And if things aren't filled out correctly, then it's very hard for us to be able to say this is what we did. And so that's why the documentation is so important. So, again, not getting into the details of certain incidences, but there in the last quarter that we had, there were 2 albuterol, one Narcan that we had administered, but we didn't. Again, when we talk about the indication for Narcan, the biggest thing we're trying to check for is how is their respiration rate, because that's the thing that we're trying to reverse the most out of everything when somebody's having an opiate overdose. And so if we do a baseline before and then an afterwards, then we have a clear indication if the Narcan's working. If on the report the respiration says not assessed, then we don't have any indication that the drug did anything for that particular patient. So that that's a key point that needs to be addressed. Just taking some extra time to make sure that is filled out. Again, repeating what Travis said, there was 2 that I had gone through that were on albuterol, same situation, just making sure that we're making sure those respiration rates are addressed before and after administration so that we can show that there's improvement or not improvement, and so that we can then judge what we need to do next, especially if there's not any improvement and medics haven't arrived on scene. And aspirin, the only thing there was just making sure that you're just finishing the full report on the OPQRST. So I think for the most part, I believe it's probably happening. It's happening on scene. It's just probably not just being documented in the paperwork, and that's sometimes the toughest part of the job is just getting things documented down. So just encourage you to get everything in so that it's a safety mechanism for you in case of an event where someone has some question of what actually happened during that event.
Perfect. Also, just when we're doing these reports, guys, after we've given the medication, let's try to make sure that we can actually keep the drug, if at all possible, because that firehouse number needs to match your report. There was a couple instances where the firehouse number wasn't the right drug that was given, which when we print out all these forms, the doctor's going through there, and then he sees this number and he's like, "Well, this isn't even in our inventory." So it basically means that the drug doesn't exist and that we gave something that we shouldn't have. So we need to make sure that those match up.
The only other thing is just monitoring two quick things. Temp logs. I mean, most of that's being taken care of here at Station 1. We won't have, you'll have access to that, so if the Board of Pharmacy ever needs that as they come, you should be able to pull that up from your firehouse system. Being able to give them any type of documentation they need, that won't be in the binder itself. So if they want a certain amount of time when that during the summer, you know, if they want the temps during the summer, you should be able to pull that up for them. Again, the Board of Pharmacy, when they come, they typically come May or June, and it can just be, like I said, a surprise visit. So they usually will hit the main station here and give, you know, the other stations enough time to kind of get ready. But just be aware that you need to be able to pull that information up. Just with our, lastly, at least for me, unless there's anything else that I need to add, but you know, when we had covered our adrenaline training in the winter of last year, you know, it was new to everybody, and I know, you know, it sounds like just from this last report that we just covered, there was one that we just were able to do in this last quarter, just a couple months ago, and it was done, you know, to the T of what we were hoping to accomplish. The thing that I just wanted to reiterate is, you know, in the report it said, you know, that the patient's condition remained the same. Now, this particular patient had a lot of swelling in the face and the lips, and sometimes, you know, when you're thinking about a drug, and we've talked about it on paper and in front of each other, we think all of a sudden that everything is just going to change dramatically. Well, a lot of things like swelling, those types of things around the face and the mouth, those tend to sometimes stick around for a little bit of time. I mean, the biggest thing that we're trying to achieve with the adrenaline is, again, get the breathing under control. And so when everything there was filled out perfectly, the respiratory rate was 20, blood pressure was a little high but still was within range. His O-stat was 95%. So when you look at all of the stats, even though it says the condition remained the same, he was still doing well as a patient, you know, before medics arrived on scene. I mean, the things that we would have been most worried about as a first responder would have been, you know, is that anaphylaxis happening, and is he getting the oxygen that he needs? Well, the vital signs show that he was. The other things, you know, it still might be you know, swelling across the face and the body, but again, we're focusing more on the life-saving measures and not, you know, just the run-of-the-mill things that might be happening with just facial features or hands or whatever might be swollen at the time. So,
all right. Yeah, if you don't have anything else, I think that'll be it. I think we'll turn it over to Gage and Dylan. If you guys have any questions about any of this stuff, feel free to get with me or Brandon, and I'll try to pass it up to Dr. Nyren as soon as I can. Thanks, guys.
Thanks.